Hi, I'm Stephen Bruce. I run the Academy of Physical Medicine, and here's 45 minutes of free CPD for you. This is just an example of what we do. We run a free session every month, along with 70 plus hours of live learning with others CPD every year. If you'd like to see more, click the link in the info section below the video, and that'll take you through to our website. Enjoy. Today we're going to be looking at HRT and breast cancer, as you can see from the slide behind me. And I'm joined by Susanna Unsworth, who is a GP who specialises in women's health and has been on the show before. Before we go on with this, though, of course, and perhaps I ought to explain why we look at topics like this. Perhaps it's obvious, but it is part of the osteopathic practice standards. It's part of the chiropractic code that we are aware of our wider role in the healthcare arena. Breast cancer and HRT, they're major healthcare topics. And there are occasions, frequent occasions perhaps, when patients might expect us to offer knowledgeable advice, point them in the right direction to find out more about significant health issues like this. Anyway, that's what we're going to do today. And Susanna, great to have you with us again. How are you?
I'm fine, thank you. Thanks for inviting me again.
Sorry, what was that?
As I say, thanks for inviting me again.
Oh no, I mean, you were very popular on the last occasion we came back. You were in with us, and people were keen to have you back. And I think that this is a topic which a lot of people have probably personal interest in, as well as interest on behalf of their patients. Is it a nice cut and dried thing?
Sadly not.
Take HRT or don't?
Yeah, it's quite a complex topic, and I think the evidence for it is a very emotive topic as well, I suppose, really. We're talking about breast cancer, it's often in the media, people often do worry about it, and the answer isn't quite as simple as a yes or no, basic discussion. It's about an individualised approach for each individual woman, but what I like to do is provide women with accurate information about the true risks that are involved, so that they can hopefully then make their own decision about what they would like to do regarding treatment and decide if they want to use something like HRT.
What's the first sign that might bring a woman to you to discuss breast cancer? Is it usually lumps, or is it pain, or? Yeah,
so I mean, I've worked in general practice, and I actually also work in the breast clinic at Addenbrookes Hospital in Cambridge. And so I think most women probably present there with some sort of breast lump that they found. So a woman, if she comes across something like a lump in the breast, should go see her GP, and then her GP would hopefully examine her, assess it, and the vast majority of the time actually she would then get referred to a breast clinic to have a further assessment, and I think most women present with a lump.
You're obviously an expert in this. I'm not seeking to disparage any GP at all, but are they all competent in examining the breast effectively?
Yeah, I mean, it's part of general medical training, and I'm actually involved with training medical students so that they do know how to assess a woman's breast properly. I would say the vast majority of the time, however, a woman will know if there's a change in her breast, and I think often that's the best sign. And when I was working in general practice, if a woman was concerned there was something not right, that for me would be a big marker for wanting to take things further, even if maybe clinically it wasn't quite as noticeable. I think you do have to take on board what a woman says, and if they feel that there's something not right, then it really does need to be properly assessed.
I know we want to get onto the topic of HRT, but I suppose partly I'm interested to know that in our clinical context, how we ought to be advising our patients, or whether we should be advising about anything. And if I compare this with, let's say, testicular cancer, I suspect that most men don't do any form of self-examination. Do you think women are better at that?
Yeah, I mean, I think a lot of women do examine themselves, but I hear a lot when I'm at the breast clinic, when I'm seeing women in that setting, they often will admit that maybe they don't examine themselves as often as they should. And so what we try and encourage women to do is to get to feel like they know what is normal for them, so that they can identify if there's a change. And for most women, pre-menopausal women, I would recommend they examine themselves once a month, usually sort of just after their period is the time when their breasts are usually least tender and least lumpy, because breasts do get lumpy throughout the cycle, but that often will then resolve with a period. So it's good to get into the habit of doing that regularly, and then it then allows them to identify when there's something that feels different. And rather than getting too fixated on knowing exactly how to do it, it's getting used to what things feel like normally, so they can identify if there's been a change.
That sounds like it's a useful piece of advice to pass on, that actually the lumps may appear during the course of their cycle, and that's perfectly normal.
Yeah.
Are you able to give any idea of when, let's say, a woman discovers a lump in her breast and goes for examination, what percentage of those will turn out generally to be innocuous, cysts or whatever else?
I mean, it changes a little bit. I mean, with COVID, it's been quite difficult because I think a lot of women have been delaying going to see their doctor, and actually the percentage of more worrying things, I think, has actually increased because women have left it because they didn't want to trouble their doctor. But on the whole, when I was working in general practice, the guidance was that we should probably be referring, because the amount of people that we should refer should mean that 9 out of 10 of them don't have actually any cancer. Less than 1 in 10 we would want to actually have cancer. So the vast majority of women that we see up in the breast clinic, it turns out not to be cancer.
Right. Now, I think I'm right in saying too that the more dangerous cancers in the breast are the fast growing ones. But of course, that's a rather general term. What sort of period of time do you think would there be before a woman had noticed that there was an increase in size in a lump? Or
yeah, I mean, the clinic that we have sees a woman who's been referred within 2 weeks of seeing their GP. So we do like to see people as soon as they've noticed something. So in very young women, so maybe women under the age of 30, we would often suggest waiting till their next period to see if the lump has disappeared. But probably in women above that age, any lump that you notice, I wouldn't leave it any length of time. I would say that it really does need to get checked out there and then, because potentially things can progress quickly. But the vast majority of things don't. And like we said before, the vast majority of things are actually absolutely fine. But it's much better to assess it straight away. So we do encourage women with any lump to go straight to their doctor so that we can see them in a timely fashion.
Yeah. And what then about the role of HRT in all this?
Yeah, so HRT has traditionally had quite a lot of bad press in relation to breast cancer. And I think the vast majority of women that I see, so I run a separate menopause clinic as well, and the vast majority of women that I see, I would say their number one concern about HRT is the risk of it causing breast cancer. And sadly, the information relayed to women, particularly by the media, is often incorrect and really does give HRT a bad reputation. And so I spend a lot of my time actually trying to re-educate women about the real risks, so that hopefully then they can make a choice, a proper informed choice about whether or not they would like to use HRT.
So what is the current press position on HRT? I mean, I guess the Daily Mail is one of the most widely read sources of this sort of information. Are they saying it's good, or are they saying it's bad?
It is a bit variable, and it depends what's being published at the time. So it probably all stems back to about 20 years ago, when there were 2 big studies that were published around 2002, 2003, that were actually leaked to the media prior to actually being published. And both of these studies did suggest that there was a strong, significant increased risk of breast cancer associated with using HRT. And once that made it into the media, that was it. There was no real going back from that. And sadly, one of those studies actually had a reanalysis of the data, which actually then overturned its final conclusions. But that didn't make it into the media because that's not exciting enough, is it? So sadly, I think the media is often very quick to say when something causes something negative, and not so quick to say the reverse. And then again, last year, sort of summertime last year, there was another publication in the Lancet, which again brought up this whole issue again of the increased risk of breast cancer. And lots of women got really frightened yet again because of it. And so the media, I think, often has a very negative approach to HRT. And what is sad is that they don't, well, hardly ever talk about the other health benefits that it gives you. So yes, you can talk about the risk of breast cancer, but you shouldn't really ever talk about these things in isolation, because yes, something may have a negative effect in one arm, but if you look at the other arm, there are other really strong health benefits that you get, and you've got to weigh up the overall risk and benefit of anything really before you make a decision. So I think this is one of the biggest things with HRT, is that often it focuses on breast cancer when really we should probably be looking at a whole, thinking about other factors as well.
Yes, I suppose we're hoisted by the fact that cancer is such an emotive word, isn't it? That it takes over from any other concern or benefit that might arise in the conversation.
And I think breast cancer, especially for women, I think it's probably the cancer that most women do fear. But actually, if you look at mortality rates of women in the postmenopausal part of their life, breast cancer is not the biggest killer of women. Cardiovascular disease is much more of a significant risk for mortality. And HRT actually has positive beneficial effects on your cardiovascular system. So yeah, but it has a very emotive, people worry about it, and understandably so, but I think it sadly is blown up out of proportion or disproportionate to the other benefits that you might get.
Just out of curiosity, in terms of female cancers, if I can call a cancer female, which is breast cancer likely to be more, does it have a higher mortality rate than cervical cancer?
I don't know if I've got the exact figures to hand, but although, I mean, breast cancer is a commonly diagnosed cancer, but the treatment of breast cancer has dramatically improved. So the mortality risks from breast cancer have significantly improved over the last sort of 20, 30 years. And like we were saying before, it's not one of the biggest killers of women. So, a diagnosis of breast cancer is probably not as significant as maybe being diagnosed with significant heart disease, but it doesn't have the same, in the media, it doesn't have the same scare factor. Women are often more worried by that diagnosis, which is why I think it's important that women are sort of made aware of the true risks involved, so that they can then make a proper informed choice.
So what then is the actual risk of contracting breast cancer as a result of HRT, given modern types of HRT? Yeah,
so that is quite a good question. So you mentioned about the modern types of HRT. So sadly, most of the data comes from very old-fashioned forms of HRT that we really don't use very much of. So the biggest study really that was done was the Women's Health Initiative, which was done back in 2002. And that was a study of about 27,000 women, but they were using very old forms of HRT that were used at the time. So they were using conjugated equine estrogen, which is the estrogen that was extracted from horses' urine, which we really don't use much of at all now. And it also used a very synthetic progestogen. So medroxyprogesterone is the progesterone that was mainly used in that study. And we don't really use those forms of HRT, but sadly the data that we have comes from that. So we kind of have to use what data we have available to us. The original study did suggest that there was an increased risk of breast cancer in women using this form of HRT. But actually, when they reanalyzed the data and allowed for other sort of confounding factors, they actually found that there was no significant difference. But like I was saying before, that wasn't widely widely publicized in the media. Yeah. But what's more interesting is the long-term analysis of that data was published earlier this year. And what it did show is that, yes, there is a very small increased risk of breast cancer when women take the combined form of HRT, which is the estrogen and the progestogen together. But interestingly, what it did show is that women who take estrogen HRT, which is estrogen only, they actually had a lower risk of breast cancer. So this was really, really great data that was published last year, and really has reinforced what the NICE guidelines have been recommending since 2012.
So why would any GP put a woman on the other sort, the mixed HRT?
Yeah, so that's to do with whether or not you have a uterus. So if you still have your womb, you have to have 2 hormones, because giving you estrogen is really to treat the symptoms. The progestogen is to protect your endometrium from estrogen. If it was given on its own, it increases the risk of developing endometrial cancer. So sadly, the form that most women would have to take is probably the combined form. And that is the type of HRT that has been shown to have a slightly increased risk of breast cancer. Women who've had a hysterectomy for whatever reason can have estrogen on its own, and that has been shown to actually have a lower risk of breast cancer.
Okay. I've had a few questions here. Carol says, what are the risks of the pessary HRT, if there are any different risks for that?
Yeah, so yeah, really different. And what's quite sad is that vaginal estrogen sadly has to have the same patient information leaflet within the packaging, which talks about the risks of HRT and breast cancer generally. Whereas vaginal estrogen, so little of it gets absorbed into your body that it has been shown that this does not confer any increased risk of breast cancer at all. And that is a recent British Menopause Society statement has clarified that women can use vaginal estrogen very safely, and it does not confer any increased risk of breast cancer. The data has shown that the amount that you absorb is extremely small, and the guidance for us is to say is that it's roughly about the same. If you were to use vaginal estrogen every day for a year, you'd get about the equivalent dose of 1 tablet of 1 estrogen tablet. So it's really, really, really small amounts get absorbed.
Excuse perhaps my obtuseness here, but if you're absorbing so little of it, how can it be effective?
So that's like your systemic absorption, so going into your whole body, whereas what it's doing is acting very locally just on the vaginal tissues, which is what you're sort of using it for.
Right.
So women who suffer with those sort of symptoms can really safely use pessaries or cream or whatever form they get prescribed without any worry about an increased risk of breast cancer.
Okay. Salome Olivia has asked about men getting breast cancer, and I guess men don't very often go on HRT, but she'd like to know how men might recognize the breast cancer and how they would be treated.
Yeah, so we do see men. I see men in my clinic. I mean, I would probably see a man at least 2 or 3 times every week who is referred with a breast lump. So it's the same thing, really. Men should examine themselves as women do. I think it's probably easier for a man to notice if there is a lump. However, obviously, it's easier for them to examine themselves. But yeah, any lump that a man feels in the breast area, I would say needs to get checked as much as any woman would. Again, there are other things that it can be. The commonest reason is a condition that we call gynaecology, which is where men just develop enlarged breast tissue. This can be for various different reasons. Usually it's medication or some sort of drugs that they're taking that triggers it. Although in very young boys at puberty age, that's very common naturally, and also in older men it can be very common just naturally as well. But yeah, breast cancer does happen in men, so anything that they're concerned with, I would say they should really get it checked as well.
Okay. And Charlotte says that she says she often sees patients becoming unstable mechanically or biomechanically when they're on HRT. Is that something that you've recognised?
Does she mean sort of unsteady, sort of on their feet, or?
I only have the information I read out there from her question, so I imagine that's what she means. Joints becoming more lax.
Yeah, that's not something that I would necessarily associate with women taking HRT. If anything, women around the menopause tend to suffer with musculoskeletal pain, joint pain, and HRT can often be really helpful with that. Estrogen is really important in the musculoskeletal system, in bone strength, and so often HRT is actually really beneficial for those sort of things. And this sort of takes me back a little bit with what I was saying before about the health benefits that you get from HRT. So we were saying before about how trying to take look at the whole picture, and HRT is really important in it's big factor in keeping your bone density strong and reducing the risk of osteoporosis, which again is another significant risk and mortality risk for women in their sort of post-menopausal years. So again, it's one of the other health benefits that HRT offers.
Yeah. Melanie says, what were this is a bit specific, what were the sample numbers in the positive estrogen study?
I don't know if I've got the data to hand to tell you exactly. The bits of information that I think are quite useful that I have got the data, I wrote a few notes before I came on just to so I could provide you with sort of the figures. The most recent data that was published in the Lancet, which was last year, this doesn't divide into the different types of HRT quite as closely as the Women's Health Initiative, but what it showed is that for women taking continuous combined HRT, so this is 2 hormones and they take both hormones every day, the increased risk of breast cancer went from 3 in 50, which is the baseline risk, to 4 in 50. So an extra 1 in 50 case in women aged 50 to 69. So they're the figures that came out from the Lancet data. Mm-hmm. Women that take sequential HRT, which is where you have estrogen all the time, but you have the progestogen taken in sort of sequence, sort of a monthly sort of cycle, that had a lower risk. So there was about an extra 1 in 70 cases. So combined continuous is an extra 1 in 50, sequential combined an extra 1 in 70. The thing that's slightly different with the data from the Lancet sort of meta-analysis compared to the Women's Health Initiative is that actually did show that estrogen-only HRT did have a slight increased risk of breast cancer. It's about 1 in 200, an extra 1 case in 200 women. This actually is different to what the data from the Women's Health Initiative has shown. And what's important to stress is that the data from the Lancet study is an observational sort of meta-analysis study. It was done by a group of epidemiologists. It wasn't a randomized controlled trial. So the data for it is it did have quite significant flaws. And what is also important to mention is that meta-analysis didn't include the Women's Health Initiative, which is the biggest study looking at HRT, which is interesting. And so I think that the problem is it's very difficult to explain to women clearly what the data has shown, because there is a little bit of conflicting results, and that is often what makes it difficult. But I think from my viewpoint and the British Menopause Society is that the vast majority of the data does support a very, very low risk of low increased risk of breast cancer, but the health benefits largely often outweigh that. So the health benefits from a cardiovascular point of view, the health benefits relating to osteoporosis really do largely outweigh it. But it's an individual decision to make. I think, a lot of women will want to talk about their individual risk. There are other factors to take into account, other lifestyle factors that a woman might have that may potentially put her at a higher risk. Things like family history can put her at a higher risk. So it's not a straightforward answer, sadly.
We talked about something related to this before we came on air, and of course let me start from a different perspective. You mentioned 1 in 200 increased risk of breast cancer. That sounds reasonable. It's not too high, but you also said 1 in 70. When you get to 1 in 70 and 1 in 50, 2%, I would start to worry. I would have thought, actually, that's not very many people. That's a high percentage.
Yeah, I suppose, it does sound quite scary. And I think the way the media portrayed it is that it went from 3 in 50 to 4 in 50, which is a third increase. And so when you say it like that, it does sound like a lot. But when you look at it sort of maybe the other way around, so 1 in 50 means that an extra 1 case in 50 women that are taking HRT, an extra 1 of them would get breast cancer. But actually 49 of them wouldn't. And so if you look at it sort of in the reverse, it's, it does make it a little bit more proportional. And then if you think about other lifestyle things that have a much more significant risk. So I often talk to women about the risk of alcohol. So alcohol consumption, so drinking more than 2 units of alcohol a day, is more risky with regards to breast cancer than using HRT. And the biggest one is actually obesity. So women whose BMI is over 30 have a significantly higher risk of breast cancer when you compare it to using HRT. And, you know, these sort of lifestyle things often don't get mentioned in, you know, in the media of how significant they are. So I think for most women, it's about putting it into perspective. But also it's about a quality of life issue. So a lot of women that I meet, particularly going through menopause, are having really, really severe symptoms, really, really struggling, and their quality of life is really poor. And, you know, for a lot of those women, that small increased risk is worth taking if it's going to give them their quality of life back. One thing I like to just point out, and I often say this to women in my clinic, is that when we're talking about the breast cancer risk, we're talking about a diagnosis of breast cancer. When you actually look at the mortality rates, there is no increased risk of mortality. And actually, both of those big studies have shown that's the case. Yes, they might be more likely to be diagnosed, but they're no more likely to die from breast cancer. And if you look at overall mortality, women who use HRT actually have lower mortality rates than women who don't, and that's because of the health benefits with regards to cardiovascular disease.
That was actually the question I was going to ask you a moment ago when I sidetracked myself, because I thought actually telling people there's an increased risk of cancer is one thing, but you know, the overall mortality is
exactly,
so often overlooked.
Yeah, and we think that the reason for that is probably because they're more likely to be diagnosed with an estrogen receptor positive breast cancer, which is actually much more effectively treated, although I haven't gone into the details about that really. But yeah, I think that's a really important distinction to make, that actually, you know, yes, you may have a diagnosis, but the risk of dying from it is less, and actually the risk of dying overall is less because of these other health benefits that you get from it.
Yeah, I don't know if you're a fan of his. He's certainly a bit of a Marmite character, but Ben Goldacre has written quite a lot about the misuse of statistics in the press and other
I think
places.
and this is a classic case of that. I think it's like I was saying before, the risk went from 3 in 50 to 4 in 50, and that was portrayed in the media as a 33% increase.
Which sounds huge, yes.
Yeah, and when you say it like that, it sounds absolutely awful. But 33% of something small is still something small. And, you know, I think that's often what is sadly portrayed. The media is good at sort of representing data in that way.
But the other thing that came out of, I can't remember which of Ben Goldacre's books it was, but in one of them, he also talks about the quality of the health reporters in much of the mainstream press. Even in what we would regard as being more reliable newspapers, quite often the people reporting on health have got no background in health at all, so they don't really know what they're talking about. You have to bear that in mind when you look at the way they interpret the stuff they're being fed by scientists involved in a study who might have a personal interest in that study.
I think that's, you know, it's really important to take all those factors into account. And this is what happened sort of summertime last year. I had lots of women coming to me saying, I've just seen this on the BBC Breakfast or whatever, and I'm really worried about my HRT now. And what was really important to stress to those women is that the data that had been published actually didn't give us any new information. Most of what they were saying we already knew and was already being taken into account with the NICE guidelines and how their treatment was being managed. And so it really had no impact on the vast majority of women's treatment, but it did scare a lot of them, and it's a real shame. I think sorry, I was just going to say one of the other things just to point out is that the increasing evidence now for the newer forms of HRT. So what we tend to use now is a more natural, we use a lot more natural forms of HRT, things that are what we call body identical, so the hormones are identical to what our bodies naturally produce. And there's increasing evidence now that these are actually much safer in regards to breast cancer as well. So whilst the risk before was small, we hope that actually these newer forms of HRT have an even better risk profile. And hopefully as time goes on, we'll have more data to back that up.
We've had a slightly technical question from Yvonne. She says, She says, would that be the case for people with BRCA gene? Is that the BRCA gene? Is that what it's called? Mutations of it, BRCA1 and BRCA2. Would they still get the combined HRT?
Yeah, so it's slightly different. Yeah, so what you have to bear in mind with situations like this is that these women have a slightly higher, well, it's not slightly higher, they have a higher baseline risk for developing breast cancer. And you have to take that into account. So their overall risk is going to be greater regardless of the HRT because their baseline risk is higher. For the vast majority of women who have either a family history or are known to have genetic mutations that increase their risk, HRT doesn't increase the risk any further than it would for any other woman, but obviously they're starting at a higher baseline, so the overall risk is going to be higher. However, I have used HRT in women who are known to be BRCA carriers, particularly in the women who've had treatment, sort of prophylactic preventative treatments. They may have had oophorectomies, they may have had mastectomies, depending on the situation. I have used HRT in these women because again, the health benefits generally are going to outweigh that increased risk. But it is an individual assessment. But what I find frustrating is when women are automatically told that they can't have HRT because of, say, a family history. So I find that happens a lot, and that's not true. In my practice, I would say there's probably no woman who I would say that she definitely could not have HRT unless she maybe had someone who had an anaphylactic reaction to it. I would say that the vast majority of women, it's about a risk-benefit analysis. And I think that is very variable from each woman, each individual woman.
Just remind me then, what would be the normal family history problems that might cause someone to say you can't have HRT?
So, I mean, I'd say would see quite a few women in my clinic who maybe their grandmother had breast cancer, or even their mother may have had breast cancer. So obviously that puts them, they're anxious about that family history. And I think a lot of doctors, general practitioners would feel a little bit uneasy in just saying, oh yeah, HRT is absolutely fine. Because women with a close family member, particularly maybe a close family member who's had breast cancer at a young age, yes, they are at an increased risk of developing breast cancer themselves. But it's like I was saying before, it's about their baseline risk. Their baseline risk is going to be a bit higher, but the addition of HRT does not increase that any more than it would another woman. But because we're starting at a higher point, the overall risk is going to be higher. But it's about someone's risk-benefit assessment and how much their problems are affecting their quality of life, and then they can make a decision.
Does it complicate that overall mortality equation, or is it still the case that yes, there's a history of breast cancer, take the HRT, you might be slightly more likely to get breast cancer, but overall you're less likely to die?
Yeah, I would say they would still get the same health benefits. So the reason the mortality rate is lower is it's the same. Yeah, so I feel that would be identical. So the health benefits would still be the same.
Anna has asked whether transdermal estrogen is better in terms of risk than oral.
Yeah, so in regards to, so not necessarily in regards to breast cancer, in regards to things like thrombosis, transdermal estrogen is much safer. So we know that using estrogen through the skin does not confer an increased risk of clotting problems. Mm-hmm. So for the vast majority of women, I often encourage them to use transdermal HRT anyway, because I kind of feel, why would you want to use a product that does have an increased risk of a blood clot when there's something available that doesn't? And also it gives you a more constant dose, which I think is much more effective. So for the vast majority of women, I encourage transdermal estrogen. The breast cancer risk, if we're taking the Women's Health Initiative data, which I think is the most accurate data to work from.
Is that an ongoing study? Or is it?
Yeah, I think it has concluded. I mean, actually, I don't know whether they're carrying on now. That it was a study that was done sort of in the late 1990s, and then they were followed up, and that was republished just earlier this year. So yeah, it's been a very long-term assessment, what it showed is that it seems to be a combination of the estrogen and the progesterone together that confers this increased risk of breast cancer. So what I try and encourage women to have is a transdermal estrogen and then a very natural progesterone, so usually using something called micronized progesterone, which is chemically identical to our body's natural progesterone, or potentially using the Mirena coil to deliver the progestogen. These have been shown to be much safer forms of progestogen in regards to breast cancer risk. But giving it through the skin doesn't really necessarily affect the breast cancer risk. Okay.
Eva has asked whether women can take HRT over the age of 55. Are there any benefits?
Yeah. So a lot of the data that I'm talking about is looking at women aged 50 to 69. So that's kind of the age group that we're thinking about the breast cancer risk. Using it above the age of 55, there is no problem with that. What we try and encourage women to do is start HRT close to the time of menopause. The reason for that is if you delay using HRT beyond menopause, the cardiovascular risks start to increase. So we would encourage women to use it closer to the time of menopause, but there is no exact age that we would say that you couldn't use it. Age between 50 and 60, the health benefits far outweigh the negatives. So in that age group, I'd be quite happy for women to carry on.
Interesting you say that about cardiovascular disease. Anna sent in an observation. A patient has been told that she can't have HRT because she suffers from familial hypertension. Is that correct?
No. So whenever we start someone on HRT, we do often look at risk factors, and we do want to look at their cardiovascular risk factors. But if she's got adequately controlled hypertension, there is no reason that she can't have HRT. If anything, it's going to actually offer her a benefit because it's going to be cardiovascular protective. So for me, a woman who's got a family history of high blood pressure, she's someone who I'd be thinking, actually, you're likely to get health benefits from HRT rather than saying she can't have it. And HRT doesn't increase blood pressure. I think a lot of people think that that's one of the side effects from it. Data has shown that there is no blood pressure does not increase with HRT, so it's really quite safe to use.
So that might be quite useful for Anna to take back to that patient, because that sounds like a very important piece of clinical advice. Yeah. You confused me slightly there, because a moment ago, I mean, earlier you said cardiovascular risk is improved with HRT. You said it again, but in between you said actually cardiovascular risk gets worse over the age of 55.
Well, what happens
if you start the HRT later.
Yeah, so what happens is premenopausal age women, the estrogen in your body is protecting your heart and blood vessels. It's really cardioprotective. Once you get to menopausal age, that protection, if you're not using any HRT, starts to decline, because obviously your estrogen level starts to decline. And over time, you start to develop cardiovascular problems. So the atherosclerosis forming inside arteries, the changes that start to take place in sort of heart and blood vessels over time start to take place. So the longer we leave it beyond menopause, more of this damage has occurred. If we then introduce estrogen, say 10 years down the line, if you've already developed sort of furring up of your arteries and these sort of symptoms, potentially estrogen can disrupt that and cause little bits to break off, which can lead to things like heart attacks and strokes. So there is what we call a window of opportunity for using it in respect to the cardiovascular system. So ideally, you want to use HRT within 10 years of menopause. I do sometimes use it beyond that. And this is maybe where we might take other factors into account, such as someone's blood pressure, maybe their cholesterol. If they were very high risk for already having significant cardiovascular disease, we may not want to put them on HRT at that point. But around the time of menopause, that would, for me, would be the perfect opportunity to do it.
Are there other medications which contraindicate HRT?
No, not really. I can't think of anything that I would say you shouldn't use HRT alongside. I mean, if you're using the contraceptive pill, if you're using a combined contraceptive pill, you wouldn't necessarily use HRT alongside that, because they both contain estrogen and the progestogen. But you can use the progestogen only pill alongside HRT, because one important distinction is that HRT isn't a contraceptive. So that can sometimes, be a factor. So it's important to make that distinction. So no, there aren't really any medications that come to mind. I would say you shouldn't use them alongside.
Okay. I've had some a follow-up on that business of instability. Charlotte says that her patients on HRT often get instability in the pelvis with pain along the inguinal ligaments bilaterally and pain over the medial malleolus and their medial wrists bilaterally.
Oh, no, I mean, I'm not particularly aware of it causing any very localized soft tissue, connective tissue issues. For the vast majority of women, I think those problems tend to improve. I know that those sort of things are often an issue around pregnancy, aren't they, as well? Women can often get pain issues, particularly in the pelvis and the wrist problems in pregnancy. I mean, in my experience, I would expect HRT to actually improve that. So whether the women in this situation maybe need their HRT reviewing, and whether it's actually not adequate or not managing it properly for them, that would be my thing. That would be my suggestion to look at, rather than it being the HRT causing it.
Yeah, it would be an interesting study to conduct, wouldn't it? I imagine, I don't know, but I imagine that they've done an extensive review of the adverse side effects of HRT, which ought to include joint pain. But
yeah. I mean, some women do get some side effects from using HRT. It's usually the progestogen that causes a lot of the side effects. So breast tenderness, bloating, nausea, that sort of thing that women often experience when using the progestogen. Sometimes the estrogen can give nausea. This is another reason why I don't often like to use it orally, because I think oral estrogen often makes people feel a bit nauseous, whereas using it transdermally can often improve that. So it's not without side effects, sadly, but for the vast majority of people, they don't experience significant issues, and they notice significant improvements from their menopausal symptoms usually pretty quickly.
Sophie has sent in an observation about estrogen being key to collagen formation and being anti-inflammatory, and ligaments and therefore joints can improve greatly with HRT.
Yeah, that's my experience. Yeah.
And Vanessa says, what are your thoughts regarding natural progesterone, e.g. wild yam products?
Yeah, so we do have women who have definitely used these products with some benefit. The difficult thing is with a lot of these natural products is the sort of level of regulation and how much is in them and how safe they are is very difficult to establish, because there's not enough data to sort of support their safety. So on the whole, I don't encourage women to use these sort of products. I think I much prefer to be using something that I know is well regulated. I know what doses are safe, what doses are going to be effective, and I know the potential risks involved. Interestingly, a lot of the HRT I use is actually synthesized from yams, so it comes from these natural products. So if people are sort of worried about using something natural, actually that's where most of the HRT comes from these days. So it's gone are the days where we extract it from horses' urine, really. So if that's something that women are interested in, then actually the standard HRT can offer that. So that's
I suspect we probably deal with not perhaps more patients, but a greater percentage of our patients might be more inclined to use a non-drug intervention.
Yeah.
But of course, as you say, if you have no idea of the dosage and the outcomes,
I think that's it. I think it's knowing how safe is it, and sadly a lot of these kind of natural herbal treatments, they don't have to go through a huge amount of regulation to be able to be sold, unlike medicines that do have to go through lots of regulation. So
but for the same reason, nobody's doing the tests on them, because there's no money to be made.
Exactly, and that's one thing I often say to women is just because there's no evidence to say it works, it doesn't mean it doesn't work. It just means that there hasn't been enough study looking at it, and usually that is because of the money involved, isn't it, sadly. So I mean, I think for most women, they likely are safe to use. But whether they're going to offer the benefit that you need, probably not.
We've kind of strayed away back to HRT, which I know we talked about a lot last time, because when you were on, we were talking about menopause, weren't we? But Amy, for example, says, how do you find women cope when they stop their HRT?
Yeah, so it's really variable. And I think one thing that I often stress is that women should never be told they have to come off their HRT because they've been on it too long. That there's no definite length of time that you should stay on it for. What I tend to encourage women to do is gradually reduce it down and see what happens with their symptoms. So what we're hoping is that HRT is kind of bridging the time when their body is kind of resetting its balance in respect to the hormones. And then hopefully when we withdraw the HRT, they're at a steady state, come out the other side of everything, and everything has settled down. But you will find that women's symptoms do sometimes come back, in which case I would just go back up with the dose and leave it maybe another 6 months and then try again. And again, it's all about an individual process. I would never encourage a woman to come off HRT unless she felt it was the right time for her. I often say this to women in my clinic, if you're just about to move house or you're just about to change jobs or something, it's probably not the time to be coming off the HRT as well. And they've got to feel like it's the right time for them. But for a lot of women, if you gradually reduce it, then they're usually okay.
One final question, if I may. I don't know who sent this one in, but they've asked what effect there is on women's testosterone as a result of HRT.
So testosterone around the time of the menopause does start to decline. So, about 50% of testosterone is produced in the ovaries, so it does start to decline. Standard HRT doesn't contain testosterone, but I often do use testosterone in my practice. The sad thing is in the UK is that there's no licensed product available for women to use as a testosterone supplement. So either we have to use male products and give them 1/10 of the dose, which is not ideal, or there is a product that is imported from Australia, which is designed for women, but it's not available on the NHS, sadly. And I think a lot of GPs feel a little bit uneasy about prescribing testosterone because of this lack of licensed product. So a lot of women do miss out on being able to have testosterone. One thing I would say is that testosterone is usually only effective if you've got adequate estrogen in your body. So using it on its own is often not very effective. So I'd often recommend it's used in combination with some form of HRT as well. But yeah, I use it quite a lot.
That's the end of our time, Susanna. If I were to say there's their one big takeaway message from this, I think for me it would be being able to advise patients that never mind what the press says, your overall health and overall mortality is going to improve as a result of HRT, even if there is a tiny risk of breast cancer.
I think that's a perfect sum up of the situation, actually. And I think it's important that no sort of risk is taken in isolation. I think you have to weigh it up in combination with lots of factors in order for someone to make their own personal choice. And also it is a personal choice, and so I don't think a woman should ever be told that she can't have HRT. I think it's about a risk-benefit assessment, and that will be different for every individual.
Brilliant, thank you. It's been a real pleasure having you on the show again. Thank you for giving up your time. I'm sure we can find something else we can get you into in the not too distant future.
Nice to speak to you. Thanks.